we'll just give that. Perfect. Thank you. So why don't we get started? It gives me great pleasure this morning to invite Dr. Rajiv Mooney, who's one of our staff vitreoretinal surgeons at St. Michael's and Sick Kids, and also the Vice Chair of Clinical Research in our department, but also just a guy who is revolutionizing the treatment of retinal detachment. He's been traveling the world, winning lots of awards, and questioning the management of retinal detachment and repair, and if there's better ways to do it. And the imaging findings that he has are quite striking. So I look forward to his grand rounds to our department today. He's been traveling the world, and it's always nice to see members of our department successful and representing us well on the global stage. So Rajiv, thank you for everything you're doing. Thank you for being a great clinician to our patients and a member of our department. Congratulations on all your success. And I also want to welcome Saba and Sumana, our residents who will be presenting with Dr. Mooney this morning.
Thanks, Simon. Thank you for that kind introduction. It's really an honor to be presenting at UofT, which is, where we all work together. So it's great to have this time for us to interact. So today we have two presentations by our star residents. Saba is going to go first, and then Sumana.
All right. Can you see my slide?
Yes.
Great. Okay, so hi everyone. My name's Saba and I'm a PGY5 resident, and today I'm going to be presenting to you guys a case that I saw in clinic that hopefully combines medical retina and surgical retina topic. So our patient's a 70-year-old female presenting with blurred central vision bilaterally. She reports she's had metamorphopsia as well, more noticeable on the right eye than the left. And she notes these symptoms have been mildly progressive for the past several years, and she's had particularly difficulty with reading. She's otherwise has no symptoms, and she's pseudophakic, otherwise healthy. So her best corrected vision is 20/40 plus 2 on the right, 20/30 on the left with normal pressure in pupils. Fundus exam here is shown by Optos images. The slight difference in exposure in yellow areas are artifact. The exam shows healthy appearing optic nerves and vessels and some parafoveally. However, we see some graying and hypopigmentation, particularly temporally to the fovea in the right eye. Her fundus periphery, though, appeared normal. Here we have OCT macular slices that are going from superior to inferior in the right eye and the left eyes here. Does a volunteer here want to let us know perhaps what they see in the right and left eyes on OCT?
So in the right eye, there's a little juxtafoveal cyst, and then there's a temporal foveal cyst in the other eye. There's also some ellipsoid zone disruption in the right eye.
Great, thank you. So the OCT, as you said, has a temporal juxtafoveal outer retinal cyst in the right eye. And here we can see some ellipsoid zone disruption and then some ellipsoid zone loss more centrally temporal to the foveola. And on the left eye, we have this small inner retinal cyst, and the ILM overlying this juxtafoveal cyst is intact. These scans are from the most recent OCT of the patient in 2025. So looking at these areas over time, we see that there's slow progression overall in either eye, and there's actually is mild expansion of the ellipsoid zone loss that we see particularly in the right eye since 2023 to 2025. If we could launch the poll question here. So what the group thinks is the diagnosis here. So we have age-related macular degeneration, adult onset foveomacular vitelliform dystrophy, MACTEL type 2, macular hole stage 2.
Give it a few more seconds, Saba.
Thanks.
There you go.
Great. So it looks like most people guessed MACTEL type 2, and all these are certainly included in the differential. And yes, our patient here has macular telangiectasia type 2. So macular telangiectasias were first described by Donald Gass in 1977, and he described it as bilateral paracentral capillary telangiectasia of unknown cause. MACTEL is actually a group of retinal disorders originally defined based on abnormalities of the macular vasculature, and three subtypes have been described. So we have type 1, that's a congenital unilateral disease, typically in young males, and it's a presumed variant of Coates disease. Type 2, or often simply called just MACTEL, is slowly progressive bilateral, affecting middle-aged and elderly individuals, and they have macular capillary changes, capitations, loss of outer retinal structure, and eventual macular atrophy. And type 3 is rare. It's poorly understood, but it's characterized by bilateral severe occlusive vasculopathy. For our discussion today, we'll just focus on type 2 or MACTEL. So we know that retinal telangiectasias have been described in several conditions, including diabetic retinopathy, retinal vein occlusion, radiation, retinopathy. But the highlight here is that MACTEL is bilateral, it's temporal juxtafoveal, and it's idiopathic in origin. So the age of onset is usually between 40 to 60 years of age, tends to be a little more common in women. And the overall prevalence is between 0.02 to 0.1%, but this is likely underestimated because the assessments were based on fundus photographs, so they can miss early detection of the disease. Some pedigree studies have suggested that it's autosomal dominant with reduced penetrance and variable expressivity, but there's no single genetic defect that's been found, so there's likely interaction of the environment as well as the genetic makeup of the individual. MACTEL tends to be geographically localized in an area here you can see in black called the MACTEL zone. And interestingly, regardless of the degree of damage, the structural and functional abnormalities are usually limited to this oval area. The changes almost always begin temporally, and then they progress circumferentially on either side as the disease progresses. And studies have shown that the horizontal width is usually no bigger than the distance you have from the temporal disc margin to the fovea, or distance D. That's usually about 3 millimeters. And the vertical is usually no taller than 0.8 D, so it's usually wider than it is tall. If they have neovascular changes, though, it can be larger than this oval area. So we'll go over some typical clinical findings in MACTEL. These are some fundus photos with corresponding early and late IVFA frames. So first we have blunting of the foveolar reflex that can be seen early in the disease, as well as angiographic leakage you can see here. Late hyperfluorescence on FA is actually an earlier sign than the vessel alterations that we can see, such as telangiectasias. Then we have reduced retinal transparency, or retinal graying, that you can see here. And this can actually be one of the first visible changes on fundus exam. It usually starts in the temporal foveola and then spreads circumferentially along the paracentral area. We don't really know the cause of the graying, but it may be due to structural changes in the neurosensory retina that leads to changes in light scatter across the retina. Generally speaking, the area of pigment loss tends to be larger than the region that shows leakage on FA. And this is a potential clue that the vascular changes in MACTEL may actually be secondary to a reaction to some other primary insults, such as the metabolic or neurodegenerative one. And here we have some examples of other findings. So we can have crystalline findings or crystalline deposits in these patients. You can see these yellow punctate areas in E, as well as some in G. And these are seen about half of patients, and they're located at the level of the ILM. They can present at any disease stage as well. The vessels can be a bit difficult to see on fundus photos, but they can be associated with blunted and dilated venules. And these vessels appear not to narrow as they should as they approach the foveola, as you can see here. And they suddenly seem to dive into the deep retina at a right angle. Foveal atrophy may also appear as foveal cysts, as you can see here, and they can simulate a pseudolamellar hole. And the natural endpoint of the disease appears to be thinning or loss of the photoreceptor layer. And so the progression can lead to a full thickness macular hole. And because it's degenerative, there actually is cellular instability in terms of the foveal structure. So surgery is usually not as effective for these patients compared to regular macular hole repair. So they can have failure of the macular hole closure, they may not have functional improvement, and they can have reopening of the hole. And lastly, we have pigment plaques, and they're often associated with dilated venules that you can see here in red. They appear to originate from RPE hyperplasia and they migrate up into the retina. They're an important sign of scotomas because usually photoreceptor loss precedes development of these pigment plaques. And rarely patients can have a central pseudo-vitelliform lesion that you can see in yellow here, and that's accumulation of photoreceptor debris or lipofuscin in the RPE. And of course, you can develop neovascular complexes that can complicate the disease course at any point, and they're often also temporal to the fovea, and they can be associated with retinal edema, hemorrhage, and exudates. They can also appear fibrotic and inactive with surrounding pigmentation and atrophy. And although in AMD we have neovascularization as well, this is different from CNV because they seem to originate from the actual retinal vasculature rather than the choroid. To quickly go over some OCT findings as well, this is a normal macular OCT. And one of the earliest signs can actually include temporal enlargement of the foveal pit that you can see here. And that seems to be due to changes in the outer nuclear layer that's been lost and thinned out here compared to normal. If, however, you have capillary leakage in the same area, then you can get retinal thickening in the inner retinal layers. Hyporeflective cavities that you can see here in D and E happen in the inner retina, and it's usually located in the temporal slope of the foveal pit. And this is actually similar to our patient's left eye. And atrophy rather than exudation seems to lead to formation of these cavities. You can then have detachment of the ILM that you can see here from the foveolar retina with apparent flattening of the pit that you can see here. Patients also develop disruption at the level of photoreceptors, as in E, and that can progress to atrophy and outer retinal cavities that we saw in our patient's right eye. The cavities can subsequently collapse, leading to apposition of the inner retinal layers onto the RPE, the pigment epithelium, and then you can get pigment plaques that migrate up from the RPE into the retinal tissue. Eventually, the ILM can be disrupted and lead to lamellar or full thickness macular hole, or they can get complete atrophy with RPE hyperproliferation you see here. So there's been advancements in characterizing the findings in MACTEL, but there's still debate with regards to its pathophysiological origin. Histological studies assessing donor eyes with MACTEL have shown abnormally dilated vessels in the deep plexus of the retinal vasculature that initially had indicated vascular source of pathology. But histology has also shown striking loss or displacement of the central macular pigment, like lutein and zeaxanthine that we know of, and whether the pigment is associated with nerve fibers of photoreceptors or Mueller cells is unknown. And it's possible that without this pigment to filter blue light, then patients are more prone to light damage of photoreceptors. So these two bottom photos are dissected globes of a normal eye, so you can see the normal central pigment. And these top two are from dissected globes of a patient with MACTEL type 2, where you can see the absence of macular pigment centrally and a little bit of pigment scattered as a ring eccentrically in each eye. They've also noted lack of reactivity to Mueller cell markers within the area of this pigment loss, most likely because of loss of Mueller cells. So because of this, over time, the vascular MACTEL hypothesis has shifted to a favored neurodegenerative origin. So this means that the characteristic abnormal vessels may be developing from increased VEGF expression in response to a primary neurodegenerative or metabolic phenomenon. Mueller cells have become the hypothesized origin of MACTEL through imaging, histological, and mouse model studies. So here we have a normal macula stained with a Mueller cell marker that lights up uniformly in red. But here we have a patient with MACTEL where we see loss of the central area of red or the central area of Mueller cells. And this distribution of loss is closely correlated with the same area of loss of macular pigment. Mueller cells provide nutritional and regulatory support to both the retinal neurons and the vascular cells. And they also protect photoreceptors through release of these neurotrophic factors like ciliary neurotrophic factor or CNTF. They also maintain the blood-retina barrier by secreting VEGF. So the involvement of Mueller cells in supporting both neurons and vessels suggests that their dysfunction may be a central feature of MACTEL. And if we go over the treatment for MACTEL in absence of retinal neovascularization, it's actually mostly supportive since there's no current proven therapy. So grid laser, photocoagulation, PDT, and anti-VEGF injections have been tried, and it's been without success. So anti-VEGF agents seem to be able to reduce leakage on FA during the short term, but they don't actually improve vision or prevent vision loss. And there's actually question of whether they might make progression more likely during the long term. In patients with MACTEL who develop neovascularization on this side, anti-VEGF agents have been shown to help limit scarring and vision loss. And for patients with full thickness macular holes, holes that seem to come from disintegration of the foveal tissue don't do well with surgery, and their closure rates are lower than those with traditional macular holes. So we see that there's little in the way of treatment for non-proliferative MACTEL. So we go back to the drawing board from our histological and animal model studies. We set the hypothesis is that MACTEL is primarily neurodegenerative with secondary vascular alterations, and likely the primary site of this has been hypothesized to be Mueller cells. So as a result, more research has shifted to a neuroprotective strategy, and we said before that Mueller cells release neurotrophic factors, including ciliary neurotrophic factor, or CNTF. Studies have been done on CNTF, and they've shown efficacy in slowing photoreceptor loss in 13 models of photoreceptor degeneration. And this is a slide of a dog animal model, actually, of photoreceptor degeneration. And they showed that there was protection of the outer nuclear layer in the experiment treated with CNTF compared to controls where you have a thinned out outer nuclear layer. So if we have a potential vehicle to provide CNTF, then treatment can be aimed at preventing photoreceptor loss. CNTF, though, has a very short half-life that's within minutes, and our current standard of delivery, for example, by intravitreal injections, isn't viable. So that's the basis for encapsulated cell therapy, or ECT for short. ECT has been developed from allogenic human RPE cells transfected with the CNTF gene to steadily release CNTF. It has this membrane that protects the cells from rejection by the host immune system. And the semi-permeable membrane allows outward diffusion of the CNTF that's produced by the genetically modified RPE cells and inward diffusion of oxygen and nutrients from the host to support survival of the RPE cells. This intravitreal surgical implant that you can see here has been called NT501, and it's shown enlarged here. Results from the use of the implant in MACTEL have been positive in phase 1 and phase 2 studies. The 3-year phase 1 study showed the implant was well tolerated, with the main adverse event being 1 millimeter of miosis in about 20% of patients. Although it wasn't powered to detect efficacy, they did note increased retinal thickness in 7 to 9 zones measured by OCT in the study eye, but they saw reduced retinal thickness in the fellow control eye, which is consistent with the previous animal models of the outer nuclear layer that we showed earlier. This is just quickly showing the implantation technique. So you make a 3 millimeter full thickness sclerotomy in the pars plana, remove the implant by the orange gripper, put a double-armed proline suture through the fixation loop, insert the implant perpendicular into the eye, then you press the gripper to release, and you secure the loop with a 3-1-1 tie of the proline suture and pass each arm through the sclera and another 2 passes on each side to secure the implant. And this is what it looks like magnified inside the eye. So then in a 2-year phase 2 RCT of 99 eyes, randomized to NT501 implant versus sham, they looked at the ellipsoid zone loss similar to the area that our patient had. And they showed that sham eyes had 31% greater progression of neurodegeneration than treated eyes that was statistically significant. And although 0.05 millimeters squared less photoreceptor loss may seem small, if you think about it, that's about a 224 by 224 micron area, which in retinal terms, especially in juxtafoveal location, can be significant. In these patients, vision may not be sensitive enough marker of progression, so microperimetry and reading speed may be more appropriate measures. And in this trial, the retinal sensitivity by microperimetry was highly correlated with the change in area of the photoreceptor loss. And it's actually one of the first trials that correlated OCT measures of retinal structure with function using microperimetry. They also showed that reading speed deteriorated in the sham group by about 14 words per minute with no loss in the treated group. Also, interestingly, these studies were led by our own Dr. Emily Chu. So then we have 2 identically designed parallel phase 3 RCTs across 47 centers in the US, Europe, and Australia. And they ran 2 phase 3s at the same time, 115 eyes in one and 113 eyes in the other. Here in red, we have the progression of ellipsoid zone loss in the controls, and blue is the patients with the anti-F implant. So they saw 56% and 29% relative reduction in the ellipsoid zone loss over 2 years. That was in keeping with the original phase 2 study. And for the secondary outcome, the retinal sensitivity was better preserved in protocol A, and reading speed was better preserved in both groups, with less words per minute lost in both groups. It was actually interesting, in the same week that I saw this patient, NT501, or under the brand name Inselto, was FDA approved on March 5th, 2025, and it will be available for patient use in June 2025. The implant isn't approved in Canada currently, and it may be difficult, as Canada may require more functional vision requirements, and it may be tough in these types of degenerative eye diseases where maintenance of vision or prevention of progression may be more meaningful with our current advancements. The research that's progressed in MACTEL is mostly driven by the Lowy Medical Research Institute that was established 20 years ago in 2005 to fund the MACTEL project. And the LMRI website actually is a great resource for patients and physicians. The Lowy family established this private nonprofit institute when their son was actually diagnosed with MACTEL. And since then, nearly all the research work has been supported by this single family. So since then, our understanding of MACTEL has shifted from a localized vascular disease to a neurodegenerative one. And although it's a rare disease, it has significant impact on visual function. It's also been a great model for not anchoring ourselves to established treatments we have that have worked well in other diseases like anti-VEGF, but in rethinking about the pathophysiology to drive the development of new therapies. It's too early, but it'll be interesting to see how the device will perform in preventing progression in MACTEL and its potential applications to other diseases. And for our patient that we saw in clinic, we informed her of this potential new implant that will be coming soon that may delay progression, but we'll see how it's adopted by the community soon. And these are my references. Thank you.
Great, Saba. That was a great summary of the the clinical findings and the pathophysiology. And it's very interesting that the FDA now is accepting these secondary endpoints, based on imaging, like ellipsoid zone and things like that, which creates difficulty in getting approvals in many parts of the world. The recent dry AMD treatments, for example, have been approved in the US, but are being, turned down by all the other major, or many of the major countries, Canada, Europe, and so forth. So, it's going to be interesting to see, over time, if, perhaps if these patients are treated over a long periods of time, we'll start to see visual acuity benefits and, other more functional outcomes. But, yeah. It'll be interesting to see how the uptake is for this treatment.
Yeah.
Peter, any comments, Peter?
Yeah, that was a great summary, Saba. The Lowy family story is sort of interesting. The Lowy family is a billionaire Australian shopping mall mogul. And he approached our retina specialist named Mark Gillies in Australia and said, what would it take to get a treatment for this? And he just, sort of threw unlimited resources at finding a treatment for MACTEL, and they came up with one. It's kind of like with the COVID vaccine. We have all these diseases that we think of as untreatable or incurable, and if you make enough investment in something, you can probably come up with an answer.
Yeah.
Just an interesting backstory.
Yeah, as surgical retina people, will see these patients sometimes present with macular holes, as you mentioned, and those macular holes can sometimes be quite small and degenerative looking, but with reasonable visual acuity. Sometimes the visual acuity is actually not as bad as like an idiopathic full thickness macular hole, and the surgical outcomes are kind of underwhelming in terms of the fact that there's a high risk that even these small holes that have good vision may not close with the surgery that we're doing, because it's not like a tractional phenomenon that we see with idiopathic macular hole, but more a degenerative process. And so, now, those types of cases, I don't operate on macular holes from this condition very often, but now if I do, I would consider like an ILM flap or something else to try to assist with the closure to get that glial proliferation to help it close, because just simply relieving traction is probably going to be less efficacious. I don't know, Peter, what your experience has been with MAC holes in this.
Yeah, I agree. I mean, I think probably previously, this has gone unrecognized, the source of the macular hole. And I would think nowadays, most people would resist operating on patients like this because it's just, the retina is just kind of worn away. And I think as our imaging has gotten better, we're better at diagnosing MACTEL. I think it was a harder diagnosis to make before we had our high resolution OCT imaging, and and it's become easier as awareness of MACTEL has grown. But yeah, it's not your garden variety macular hole.
Okay, great. Well,
Peter, I've got a question. It's a little off topic, but in your when you're making your incisions to do your vitrectomy, do you ever get neuropathic pain? With I'm seeing quite a bit of this with the small phaco incisions, and I was just wondering if you're seeing that as well with your vitrectomy incisions.
I haven't.
I mean, people complain of all kinds of things, but but yeah, it's a great thought, I'm probably, we haven't spent enough time, we usually attribute it to dry eyes or things like that related to the conjunctiva, where or maybe from prior surgeries like scleral buckling or multiple vitrectomies, they can have scarred conjunctiva, and they've probably lost the ability to create a good tear film. So I usually attribute it to that, but it's a good question.
Interesting, Rajiv. I'm doing some work on this, and there's a classic diagnosis, pain without stain, and we didn't see this with our larger incisions. And your incisions for your vitrectomy surgery are very similar to phaco, and yet I'm seeing it with phaco. Everyone calls it dry eye, and that's the category it falls under. I don't think it is. Because we're doing some work on this where we're doing dry eye parameters, and they don't have a dry eye. I think it's more of a neuropathic type pain. I was just wondering if this carries on posterior to the limbus as well as at the limbus, or just a little bit anterior. So interesting to know that you do see this with vitrectomy surgery as well.
I mean, our incisions are a lot smaller. Our incisions are a millimeter in size. And I mean, the cornea is full of sensory nerve fibers. So, certainly scleral buckles cause pain and discomfort and dry eye, but I'm not sure in the early postoperative period, people's eyes are sore, but I'm not sure we see long-term pain post-vitrectomy related to the incisions.
Interesting. Thank you.
Okay, great. So I'd like to introduce Sumana now, who is going to present the next case.
Okay, hi everyone. My name is Samantha. I'm one of the PGY2 residents, and I'll be talking about in vivo resolution of ballad in Rhegmatogenous Retinal Detachment. I'll also be spending a little bit of time on, where my screen go, on multimodal imaging and Rhegmatogenous Retinal Detachment as well. I'd like to thank Dr. Mooney and Miguel for the case and a lot of the work that they've included me on as well. Before we get into the case about ballad, I just want to spend a little bit of time talking about it. Bacillary layer detachment, otherwise known as ballad, is an OCT finding of splitting at the level of the inner segment of the myoid of the photoreceptors and the ellipsoid zone. And it's important to note that the ellipsoid zone is generally usually attached to the RPE, and then there's just this inner hyporeflective space. The term ballad was first used by Mehta et al. In 2018 in patients who had inflammatory conditions like toxoplasmosis or pachychoroid disease. And so the differential has traditionally included those types of diseases: inflammatory, degenerative, pachychoroid, vascular tumors, and others on the list. However, it has not traditionally included retinal detachment. However, in 2023, Dr. Mooney's group first defined ballad and rhegmatogenous retinal detachment, and they used the same definition, so it was still defined as a foveal intraretinal hyporeflective space delineated anteriorly by a hyperreflective band of ELM and remnants of the myoid zone, and then posteriorly by remnants of the ellipsoid zone. In their paper, which was led by Dr. Mello, a retina fellow here at St. Mike's, there were two types of ballad that were defined. Type 1, which had an intact anterior foveal wall, and then type 2, which had a lamellar hole. And this one was found to have a very high risk of progression to a full thickness macular hole. And so just pausing here, without OCT and the invention of OCT, we would have never been able to find this imaging finding that has a lot of implications for both visual acuity and anatomical outcomes, which we will come to. This is a figure from Isabella's paper. So figure A, B, and C are showing the type 1 of ballad, which has the intact anterior foveal wall, and figure D, E, and F show type 2 ballad, which has the lamellar hole. Figure A, B, and C show the reattachment of the retina, and we can see in patients that have that intact anterior wall, as the retina reattaches, this one is 2 hours after pneumatic retinopexy, ballad has resolved, and then right after 1 day after pneumatic, there is reattachment of the neurosensory retina to the RPE, and there's no further ballad. In patients who had the lamellar hole, even though the retina has technically reattached after pneumatic, there's just a very small layer of the ellipsoid zone left, and that scaffold is not enough for the foveal anatomy to reconstitute, and this patient ended up with a full thickness macular hole, which, as we know and as we just heard from Saba, has important visual outcomes for patients. In terms of ballad lamellar hole outcomes, this paper by Dr. Mello and Dr. Mooney's group was very important in sparking new research. And so Yang et al. In 2024, they did some research into how do ballad lamellar holes do after vitrectomy surgery, and they found that all patients who had ballad lamellar hole, their visual outcomes were about 2300 versus 2040 in patients who did not have the ballad lamellar hole. And it's also important to note that every single patient with a ballad lamellar hole in Isabella's study ended up having a full thickness macular hole once the retina reattached. And so this imaging finding has a lot of important implications into not only what type of surgery to do, but what you can tell patients about what their visual outcome will be and the need for future surgeries as well. In terms of how does this actually happen, Dr. Mooney's group has also looked into the pathophysiology behind ballad and ballad lamellar holes and rhegmatogenous retinal detachment. And they have a very great medical illustrator who created this graphic. The mechanism behind the macular hole and the ballad is thought to be secondary to hydration of the outer retina by the liquefied vitreous that enters through the break. It hydrates the outer retina and it causes tractional forces. In the perifoveal region, this manifests as outer retinal corrugations. And then in the foveal region, this manifests as both ballad. And if there's enough tractional force, you can get the lamellar hole that can lead to the full thickness macular hole as well. On a more cellular level, Govetto et al. Has also looked at ballad-related macular holes and ballad and rhegmatogenous retinal detachment. And their cellular level graphic also explains what Dr. Mooney's group looked at, which is when this fluid enters in, it splits the organelles at this weak zone between the myoid of the photoreceptors and the ellipsoid zone, and it causes that ballad retinal detachment, ballad detachment. So now that we have a little bit of background about what ballad actually is, we can go into the case. This is a 58-year-old woman. She presented to St. Mike's with flashes and floaters and central vision loss for 10 days in the left eye. She was otherwise a healthy person, and her presenting visual acuity was counting fingers at 3 feet. On dilated fundus exam, we can see this is a pseudocolor optos photo of the left eye. There was a retinal detachment from about 7 to 5, and there were breaks at 1:30 and 2. And so at this point in time, I could have put up a poll question about what kind of treatment this patient will get, but given the nature of the presentation, I think we all know this patient will end up with pneumatic retinopathy. And the baseline OCT, we can see here, there's a very large pocket of subretinal fluid, over 1,000 micrometers. And then we can see there is the ballot cavity here and the width of the ballot cavity here as well. So the patient was consented for pneumatic with SF6, and they were instructed to maintain strict face down positioning. So they were steamrolled for 6 hours. And the research fellow very diligently went in every single hour to image the patient for 6 hours after pneumatic. And then they came back for their 1 week, their 1 day, their 1 week, and their 1 month. These are all of their images, which we will go through in more detail now. So at baseline, we can see this was the type 1 ballot this patient had. And so they have an intact anterior foveal wall here. They have a very large pocket of subretinal fluid. They have outer retinal corrugations and intraretinal fluid as well. 2 hours after pneumatic, we can see that this pocket of subretinal fluid is starting to come down, but everything else looks about the same. And then 3 hours after pneumatic, we can see there are many changes happening. So the subretinal fluid pocket has substantially decreased. The outer retinal corrugations are lower frequency and lower amplitude, and there's much less intraretinal fluid as well. 6 hours after pneumatic, we can see there's resolution of ballot. So while there still is a very small pocket of subretinal fluid in the foveal region, the actual ballot has resolved. And then day 1 after pneumatic, we can see the foveal region is attached, the neurosensory retina and the RPE are attached, and there's partial recovery of the outer retinal bands. And then finally at week 1, we can see there's full recovery of the ELM and the ellipsoid zone. And then 3 months after pneumatic, the swept source OCT grossly looks great. The retina is reattached and the outer retinal bands grossly look intact. But when we zoom in, we can see there is a very small focal disruption of the interdigitation zone. This patient ended up doing very well. At 5 months post-op, she was 20/20 in that eye. And in terms of her functional outcomes, she did not have any metamorphopsia, and she only had a very small amount of horizontal anisoconia. In terms of this patient, what was really interesting and what we could see with multimodal imaging at every single hour time point is that the foveal anatomy is almost fully restored within 6 hours of this case of fovea off rhegmatogenous retinal detachment with a ballot. And the ballot had completely resolved at 6 hours, and the retina was attached day 1 post-pneumatic. In this case, what was really important was the strict face down positioning, the steamroll that was critical to foveal reattachment, particularly in a patient that has a very large amount of subfoveal subretinal fluid. The other type of positioning that we can do is direct to break. And the pro to direct to break is that it helps to prevent further liquefied vitreous from entering through the break. However, in this case with patients that have very large subfoveal heights, steamroll might be a better option. Overall, factors that affect photoreceptor integrity include the height of the detachment and the time that the retina has been detached. So this has been studied in animal models where they've looked at a confocal laser scanning microscopy of the actual photoreceptors themselves, and they've seen in squirrels that the photoreceptors start to die almost immediately, but if you restore oxygen to them within 3 days, that can facilitate some photoreceptor regeneration, growth, and recovery. I think, though, it's important to know exactly what's happening at a more anatomical level in humans. And so this is where Dr. Mooney's group comes in. And this is kind of where we're going to get into a lot of the multimodal imaging projects that he's done. So we'll start with a big seminal paper that he came out with Dr. Mello as well, which was in regards to retinal detachment staging. And so this paper came as a spinoff of a retinal reattachment staging paper, and it looks at the outer retinal bands in all the different stages of detachment, and then compare those to the length and time to presentation, as well as the visual outcome to see, are there any relationships between what we're seeing anatomically and morphologically at presentation and what actually happens to the patient down the line. In terms of the stages here, we can see there's stages 1 through 5. Stage 1 includes outer retinal bands fully intact. So it's essentially when the retina has just separated and everything is basically still normal. Stage 2, we can see there's slight turgescence or hydration of the ellipsoid zone. Stage 3 has low, split into 3A and 3B. 3A is low frequency, low amplitude corrugations, while 3B is high frequency, high amplitude corrugations. Stage 4, we start to see a loss of the structure of the outer retinal corrugations with a thickening of the ellipsoid zone. And then in stage 5, we can see there's loss of the photoreceptors, it's patchy, it's moth-eaten, and it looks like it would have a worse visual outcome. And this paper found significantly that the worst presenting stage was associated with a longer duration of retinal detachment and a worse visual acuity at 3 months postoperatively. Coming off of this paper, Elsa Hemi, who is also part of Dr. Mooney's group, studied the relationship between the stage of retinal detachment and the outer retinal band recovery as time went on. And so his paper found that if you're in a worse presenting stage, you will have worse outcomes and greater discontinuity of the outer retinal bands at 3, 6, and 12 months postoperatively. And we all know that if there are discontinuities in the outer retinal bands, then a patient can have worse visual acuity, but also worse metamorphopsia and anisoconia as well, worse functional outcomes. This kind of gets into the role overall of multimodal imaging and what Dr. Mooney's group has been doing for the past few years. This is a paper that I want to give credit to Dr. Bansal for kind of starting it all. The N of this paper wasn't very large, but I think the reason that it made it into AJO was because they're doing something very new, which is imaging patients very frequently during all stages of reattachment to see what is actually happening to the retina after the bubble goes in and the retina starts to reattach. So this paper started off a lot of the SSOCT work that Dr. Mooney's group is doing now. And then we went into the staging paper by Dr. Mello. And then from the staging paper, we started looking at the morphological features of regulated and dysregulated retinal detachments as well. And the way that we define these two detachments, so this is a dysregulated detachment, which comes from usually a large horseshoe tear. It is kind of a more explosive retinal detachment. So the vitreous enters very rapidly into the subretinal space and it causes outer retinal corrugations, rapid hydration of the retina. And this is a kind of detachment that you might want to treat more acutely versus a regulated detachment, which does not overwhelm the RPE pump. So it's usually from an atrophic hole. The fluid enters very slowly. And as we can see here, there's absence of outer retinal corrugations. And so the thinking behind this paper and kind of the main takeaway from this is that in a patient who has a regulated retinal detachment where the RPE pump is not overwhelmed and still functioning fairly well, we can use procedures like pneumatic or scleral buckle that take advantage of the natural RPE pump to fix these attachments. And also they may be less of a kind of urgent intervention compared to one of the more acute dysregulated retinal detachments. Another paper that also used imaging to kind of predict visual and functional outcomes was the outer retinal corrugations in retinal detachment theory. And so this paper came about because we've seen these outer retinal folds on OCT, post retinal detachment repair, and we know, and it's been proven in the literature, that they have poor visual outcomes. Patients that have outer retinal folds generally tend to do worse after surgery if this imaging finding is seen. And then Dr. Mooney's group wanted to take a step back and see what exactly is causing these folds and what can we do to prevent them. And so his group found that patients who have this kind of dysregulated retinal detachment with outer retinal corrugations, if this subretinal fluid is drained very quickly, such as with an external drainage procedure like vitrectomy, when the retina flattens out very rapidly, these outer retinal corrugations kind of come together and create the folds. And we can see these three corresponding corrugations that create these three corresponding outer retinal folds. And so from this paper, the thinking that came out of it was that if we use procedures that drain fluid more slowly and make use of the natural RPE pump, things like pneumatic and scleral buckle, then maybe we can help prevent some of these outer retinal folds from forming. His work is not confined to just rhegmatogenous retinal detachment. This was a paper that Dr. Mooney's group did where they compared exudative retinal detachments to rhegmatogenous retinal detachments, looking for differences in OCT findings. And there's quite a few of them, which include things like ILM undulations, hyperreflective dots, septations, and other features. But the main feature that separated the two, if you're ever looking at a patient and you're not sure if it's exudative versus rhegmatogenous, is that rhegmatogenous retinal detachments tend to have the presence of these outer retinal corrugations versus exudative retinal detachments, which do not. And so overall, I think we can see from all of the body of work that Dr. Mooney's group has produced that now we are in an age of OCT where we can actually look at the anatomical features and the morphological features of the retina at baseline, during pathology, retinal detachment, during repair, and long afterwards to see what is actually happening with the photoreceptor layers. And we found some markers that can help to predict both visual acuity and anatomical outcomes for patients. And this can help us move past this binary, this patient is MAC off and they're all in the same group, to this patient is fovea off and they have this, and this marker. And maybe that means that they need a more urgent surgery. And so hopefully we can all move forward to using multimodal imaging to help better triage our patients for more timely intervention. Thank you.
Thanks, Sumana. You gave me a lot of credit for a lot of work that many residents and fellows in our program have been involved with. So this was truly a team effort from University of Toronto, and kind of grew over the years. We kept just following a single thread and kept going on and on with it. So maybe ad nauseum. So, but basically, I think that you really summarized well kind of the variety of changes that occur. And, what we've really realized is that the outer retinal corrugations that we're seeing really tell a lot of the story about what's going on with a detachment and what are some of the implications of that. And we're now even finding that these corrugations are also related to PVR, intraretinal PVR in particular, and that these regulated and dysregulated detachments have two very different types of PVR formation. So, it's an example similar to Saba's case where just, examining the anatomy and the clinical findings and then going into the pathophysiology of it, then will help us understand the disease process better and then, come up with better ways of treating these patients. So, yeah, good job. I don't know if anyone has any questions
There's
here.
a question in the chat about who performed the imaging post-op hourly, which is a great question because all the credit goes to the research fellows who are working tirelessly. All of us who've been on call at St. Mike's, we see they always take the patients after we see them and they go and image them and they take really, really great quality images. They come in on the weekends. They're here after hours. They're here until 2 a.m. They're imaging these patients very meticulously. So it is a huge undertaking. I agree, but it produces really, really great work.
Yeah, and the interesting thing also was that, in the past, we weren't really able to examine the retina when it's attached, when it's attaching, because, if you have a scleral buckle, the eye's very swollen and difficult to take images. And if you do have a vitrectomy, there's this huge gas bubble. So one of the questions is, how do you get multimodal imaging after pneumatic surgery? we keep them in the clinic, and the gas bubble is just needs to cover the retinal tear, which may be superior or wherever. So even when we lift their head to take the image, the bubble is still occluding the retinal break. And what's very unique about pneumatic retinopexy is that the media is not hindered. And so it's given us a great opportunity to examine the retina while it's attaching, which is a remarkable thing, and that's allowed us to find out find all these kind of novel insights into it. So. And I should also say that in our department at St. Mike's, we've been fortunate to have a lot of excellent imaging devices. So we have the Plex Elite, the Zeiss Plex Elite, which is phenomenal at giving us outstanding images of the outer retina, and is able to get great images even when the retina is detached, which can be quite difficult in general. And then also the Silverstone, the Opto Silverstone has been great as well, because now we're able to examine, long sections of the retina in the periphery with OCT, and that's also given us a lot of great insights. So, it's this access to imaging, having a great model in terms of pneumatic retinopexy, and having all these outstanding trainees and fellows and research fellows and students who have been, spending hours and hours trying to examine these patients. So, that's how it's all come together.
Congratulations, Rajiv, on this, amazing body of work that has kind of changed the way we think about retinal detachment, changed the way the world thinks about retinal detachment. The work about the evolution of a macular hole and a retinal detachment is super insightful. But when we look at the incidence of macular holes with retinal detachment is pretty low. It's usually anywhere from 2 to 4%. And in the example that Sumana showed, there was ballot and there was a very thin inner retina, and it didn't go on to a macular hole, which is most commonly what happens. Is there you have any sense of what that difference is that makes some people tip over? We see super bullous retinal detachments, and we see ballot, and we see super thin inner retinas, and then they don't end up getting macular holes. Almost all of them don't end up getting macular holes. Any thoughts about what tips them over the edge into a macular hole?
Yeah, no, you just gave me an idea that we should look at the contralateral eye of the patients who get the macular holes versus those who don't, and look at and see if there's a difference in their, macular anatomy. But, I kind of think about it like how such a small proportion of people get a full thickness macular hole, like idiopathic macular hole, even though everyone's having a PVD, right? So, it's kind of interesting to think about why are certain people getting this and other people not. And I have thought about it, and, I think that there's two things. Number one, we saw that about 20, around 25% of retinal detachments had some element of this bacillary layer detachment progressing to full thickness macular hole spectrum. But in North America, I think in general, we treat these patients fast enough that we're not seeing a lot of the end stage, which is the macular hole cases. So it's very much a time dependent process. So I think you need your fovea has to be detached for a couple of weeks, I think, for you to get this full-on full thickness macular hole. So number one, in our society, detachments are most often treated relatively quickly. If someone looked at the incidence of these macular holes, perhaps in South America or Asia, it might be a different story, especially like in some places like Brazil, people are put on the surgical wait list and, wait a month for surgery. And, now they're learning to do pneumatics and things to prevent this from happening. But so one is the time. And I think that if all of these detachments were not treated and progressed, I think we'd see many more from 25% having some ballot element, it'll, and maybe 7 or 8% getting macular holes, I think that number would go up. And secondly, I think it's something that we haven't figured out yet, which is I think that there's some predisposition to having these changes, that certain patients have the substrate that will lead to this. And I think this is something we haven't fully figured out. Saba mentioned Isabella, who's done amazing work in this area. And one of the things that she did was she went to Christine Cercio's lab in Alabama and looked at normal human tissue post-mortem. And all of the changes that we see that result in a ballad, and then, we talked about how you get a retinal detachment, post-mortem, your retina detaches because the RPE is no longer keeping it attached. You also get this breakdown in the myoid zone where you get the ballad lesion. The same defect occurs there. And then you also get these cystic changes that break down the Mueller cell cone, and the Mueller cell cone separates. So the same process that occurs after death occurs in retinal detachment, the exact same sequence of events. And what you find in these in histological specimens is that there's a tissue breakdown at certain layers. So in other words, think of, like when you build a house, you lay the bricks and whatever. I don't know how you build out, but whatever, you do these certain steps. And if there's a breakdown in somewhere in the structure, the whole thing collapses, right? And in the same way, the fovea has these certain tissue planes where everything's kind of held together. And when you die, all of those areas break down and the whole thing disintegrates. And so what I think is that how well those structures are being held together determine why some postmortem eyes get these separations in these different layers. And in the same way, certain patients, whatever their substrate is, how well those tissues are held together determines why some patients get these findings and other patients don't. So, and this actually is a one paper we're working on now where we're not just looking at retinal detachment, but all macular pathology related to traction and other things that, when you start to apply traction, like from VMT and ERMs, the changes that we're seeing in the fovea are all related to these tissue planes of weakness. And so I think there's just natural variation in the adhesion and the structural integrity of those layers. So that's kind of what we're working on now and trying to, take it further.
I mean, to your first point, that should be relatively easy to ascertain. I mean, you have a huge, you have a huge cohort of patients with retinal detachments, some of whom have had macular holes. I'm sure you have, how long it's been since from their presentation to when they lost their central vision. You probably, I mean, you could easily, it seems that's an easy,
So you're saying look at the time from time.
yeah, if the fovea is off for longer, if they have a higher incidence of macular holes, then that would suggest that what you're saying is,
Yes,
be
and
true.
that's been shown. I believe that's been shown. I can't remember the exact data, but we definitely found that, this is a time-dependent process. I'm not sure if we explicitly wrote a paper on that, but it was, in our, I have to go back, but I believe that was kind of looked at. Maybe it was just an obvious thing that wasn't explicitly emphasized, but yeah, it certainly seems to be a time-dependent process, and also the extent of hydration of the outer retina. So, how much fluid flow, like we have different detachments. You have tiny breaks, you have larger breaks. The ones where there's more rapid influx and more hydration is stressing that structure more. So.
Great round, Saba and Sumana and Rajiv. Congratulations.
Thank you.
Thank you, everyone. And Amandeep had to go, but he just wanted to remind everyone that there's no grand rounds next week or the week after. Next week is Good Friday, and the week after is, I think, the department review. So it'll be back on May 2nd. So thank you very much, everyone. Take care.
Bye.
Bye.